Thank you, Klaus. Good morning, everybody. It's my pleasure to be back in Bern. I'm going to talk about the Acetabular Wall Index, and interestingly, I think this study was largely motivated from work from Bern, from Klaus and Moritz and Lorenz, and you'll see how we have kind of expanded upon that. Here are my disclosures. So here's the original paper from the Bern group looking at the Acetabular Wall Index for assessing anterior-posterior femoral head coverage in symptomatic patients. Basically, they recognized that there was a number of increasing hip preservation surgeries. Acetabular morphology correction or characterization, at least to date, has been fairly simplistic, largely based off of uniplanar analysis such as the lateral center edge angle. There's a lot of subjectivity to this. For instance, what is borderline dysplasia? Is it 20? Is it an LCA of 20, 25? And treatment obviously can critically affect outcomes. So here's just an example of how treatment can critically affect outcome and why this might be important. This is a young man who I saw. He had a crossover sign. You can see a slight retroversion as illustrated in his left hip. He underwent an arthroscopic procedure, and you can, I think, appreciate the large amount of acetabulum that's been removed both laterally and anteriorly. Here's what that CT looks like. You can see an iatrogenic type of dysplasia created from over-resection of the socket, not a particularly well-done osteoplasty on the femoral side, and we basically tried to salvage this with a PAO to try and reorient some normal hyaline cartilage, but obviously not a perfect situation, and I think lack of understanding of the acetabular morphology leads to this type of problem, and I think more and more we're seeing issues related to over-resection on the socket side. So the Acetabular Wall Index has been proposed by the Bern group as a fairly simple method to look at acetabular morphology. There are obviously other more complex ways to look at it, such as 3D imaging, but this Acetabular Wall Index that can be used on plain films, which is basically the simple ratio of the acetabular wall distance and the posterior wall distance divided by the ratio of the femoral head, can perhaps help us understand the acetabular morphology in more detail. Now again, this was done in Bern in symptomatic patients, and if you look in their paper, one of their concluding statements is that our data suggests these measures will be helpful in evaluating coverage before and after surgery, but we need to evaluate asymptomatic individuals without hip or abnormalities to establish normal ranges. And so this was, I think, what motivated us to perform our study. We had a long interest in looking at acetabular morphology in with three-dimensional measures. You've seen this paper referred to already by Harris, where we looked at three-dimensional coverage of the femoral head and retroverted subjects. And basically what we found is that there wasn't much of a difference in terms of anterior coverage between controls and retroverted patients, but we found quite a bit of difference in posterior coverage, suggesting that the retroverted socket really isn't a focal over-coverage phenomenon. Rather, it's just a normal socket redirected in an abnormal way. And here's what that looks like on a crossover. So our research questions were using measurements obtained on AP radiographs of senior athletes, and I'll talk to you what that means. With well-functioning normal hips, could we look at the normal range for anterior wall index and posterior wall index? And could we look at the differences between these indices in classic DDH retroverted or overcovered hips, comparing them to normal hips? So here's our methods. We are fortunate in Utah that we have this thing called the Huntsman World Senior Games. It's basically the Olympic equivalent for senior athletes. About 10,000 senior athletes attend these games. We were able to examine a subset of these. 560 athletes provided informed consent. You can see we had to exclude some for various reasons, but in the end we had 505 athletes, and that allowed us to look at almost 1,000 hips. Here's the patient characteristics. You can see 55% of the patients were male, or the subjects were male. The mean age was 67 years. This slide is actually the Swiss senior volleyball team who actually won in their division. Impressive group of guys. The race is almost 90% Caucasian. And we wanted to look at outcome measures. We used a variety of outcome measures, including the PROMIS score and then the modified Harris Hip score. And you can see that the mean score in terms of Harris Hip score was 97, indicating that almost all of these patients had very high function of their hips with very little hip pain. We obtained AP radiographs and frog leg radiographs with this mobile digital x-ray system. And then we had two orthopedic surgeons calculate the anterior wall index and the posterior wall index. Again, these are basically the distance from an edge of the circle to the anterior wall divided by the ratio of the femoral head, and then the same measurement for the posterior wall. And we took an average of the two surgeons for the measurements. Here's what that looks like a little bit closer up. Anterior wall index, again, anterior wall divided by the radius of the femoral head, posterior wall divided by the radius of the femoral head. We looked at crossover, again, between the two readers, and we classified the crossover from 1 to 4, basically from top to bottom where the crossover occurred. And there was almost perfect agreement between the two readers in terms of identification of the crossover sign, indicating that we could differentiate essentially retroverted hips from normal hips or those with dysplasia. Here is the breakdown of the types of things that we found in terms of looking at the radiographs. Normal coverage we felt occurred in 740 of the radiographs, classic dysplasia in 25, retroversion in 112, and overcoverage in 121. There was almost perfect agreement between the two readers in terms of identifying the acetabular wall index and posterior wall index. So the ICC, in our case, the CCC was 0.95 and 0.926 between the two readers for the acetabular wall and the anterior wall and posterior wall, respectively. We did the statistical analysis of multivariable linear regression with a couple other corrections, and we're fortunate to work with a very good statistician, so I don't honestly know all of the details of this, but I think it's fairly rigorous statistical analysis. So here's the results. In normal hips, the anterior wall index had a mean of 0.35, posterior wall index a mean of 1.13, and I'll show you what that means and perhaps put it into perspective with what the Bern group had previously published. Here's looking at specifically at the anterior acetabular wall index, and you can see dysplastics had a statistically significant lower value compared to normals, and those subjects with retroversion and overcoverage had a statistically greater amount of coverage at the anterior wall compared to normals and dysplastics. And here's looking at the posterior wall index, graphically very similar. You can see the dysplastics had the lowest value compared to normals, and retroversion and overcoverage had a greater, at least in terms of overcoverage, had a greater posterior wall index compared to dysplastics, and normal, again, all statistically significant. So in terms of discussion, understanding acetabular coverage is necessary for determining the appropriate treatment options for patients with symptomatic pathomorphology. You can do this in a number of different ways. I think this method of measuring the wall index to more completely characterize the acetabular morphology is fairly simple and can be used in a number of different populations. When we compare our results to those from Klaus's and Moritz and Lorenz's paper, basically you can see the numbers shown here on your left are pretty similar. We found slightly greater posterior wall index in our normal patients compared to what they had reported, but otherwise the numbers are very, very similar. Again, retroverted patients had a higher acetabular wall index than normal patients and a lower posterior wall index. Again, I think hinting at this idea that the retroverted socket is really not volumetrically deficient, it's just pointed in the wrong direction. Here's a similar graph that was published in the Bern paper looking at the different measurements in normal, dysplastics, and overcovered hips. And you can see the various indices down at the bottom shown in yellow. So using these techniques, I think, is a fairly simple way to differentiate between what type of socket we're dealing with. Obviously, a number of limitations in this study. We presented only a small sample of DDH patients, 25 or so out of these 990 hips, and so we're likely underpowered to make a lot of strong statements about the dysplastic case. And we were unable to determine the demographics for the overall games, but I think we feel fairly confident that this is a reasonable subset to analyze. So in conclusion, the anterior and posterior wall coverage can be measured with these indices. This type of work can help establish normal asymptomatic indices for both the acetabular wall index and the posterior wall index, and clearly comparisons between symptomatic and asymptomatic hips going forward are still needed. Thanks for your attention.